Hi, I'm Mark from ACLS Certification Institute, and in today's Mega Code review we're covering wide complex tachycardias. Now, what makes a wide complex tachycardia different from a narrow complex tachycardia? Again, it's the width of the QRS. The literature says that if the QRS width is greater than 0.12 seconds, it's considered a wide complex tachycardia. When in doubt, treat for VTach. If the complex is greater than 0.12 seconds, it could be ventricular in origin. Sometimes it's hard to discern whether it's truly ventricular or is it supraventricular with maybe a conduction problem that's making the complex a little wider. So the literature says, when in doubt, treat for VTach. Treat as though it's a ventricular rhythm, it's ventricular in origin. Now, one of the first things you'll do when you come to your patient is assess whether the patient is stable or unstable. And this is pretty easy because whether the complex is wide or narrow, whether it's ventricular in origin or supraventricular, if your patient is unstable, the treatment is the same. Immediate synchronized cardioversion. Period. Unstable patient, wide complex or narrow complex, immediate synchronized cardioversion. If the patient's stable, you have some wiggle room. Get a 12-lead EKG. Get a closer look at this heart. The literature recommends a trial of adenosine. You can certainly give that. 6 milligrams IV rapid push. And this will kind of help discern whether it's atrial or ventricular in origin. If it doesn't work, it's probably ventricular. Again, when in doubt, treat for VTach. Now, let's take a look at some wide complexes here. You can see they vary in morphology. But when you're assessing it, you want to assess, is this wide complex regular or irregular? And we're looking specifically for changes in the morphology. Does this wide complex rhythm look the same throughout the run of the rhythm? If it's the same, well, that's a monomorphic wide complex tachycardia. If the morphology changes, if the complex changes its look, then we call that a polymorphic wide complex tachycardia. And the treatment's a little different. But first, let's start with monomorphic wide complex tachycardia. In this case, we have a patient who's in ventricular tachycardia, wide complex ventricular tachycardia. Is the patient stable or unstable? Again, unstable means that the patient is showing serious signs of shock, low blood pressure, altered mental status, poor color, signs of shock. If that's the case, immediate cardioversion. If the patient is stable, our first drug of choice for stable VTach is amiodarone. Although the other options exist, most commonly we're going to be using amiodarone. 150 milligrams administered over 10 minutes IV infusion. It's not a bolus, it's administered over 10 minutes. Should the VTach, whether it's polymorphic or monomorphic, lapse into VFib, which can happen, immediately go into your VFib algorithm. Let's look at ventricular fibrillation. No pulse, no cardiac output. First drug of choice, epinephrine. 1 to 10,000, 1 milligram, IV push, every 3 to 5 minutes. There's no max on that. Now the first or second dose of epinephrine can be replaced with vasopressin. Here's your 2015 update pop-up. The American Heart Association is no longer recommending the use of vasopressin in this algorithm, only epinephrine. You can still administer your epinephrine every 3 to 5 minutes, but the AHA has removed vasopressin as a pressor in this algorithm. Now, always follow your local protocols and your hospital policies. If they're still using vasopressin and you're having success, fine, but know that the AHA has removed vasopressin as a pressor in this algorithm. Remember, when you're running a VFib arrest, generally drug, shock, drug, shock, drug, shock. First drug, epinephrine or vasopressin. Defibrillate the patient. Second drug, after defibrillation, amiodarone. 300 milligrams IV push. Rapid IV push followed with that 20 cc syringe bolus of saline to push that medication to the heart. Now, if amiodarone isn't available, lidocaine is still a great option for VFib. The dose, 1 to 1.5 milligrams per kilogram, IV push. Repeat doses are half of that to a max of 3 milligrams per kilogram. You'll find in the clinical setting that a lot of practitioners tend to use what works for them. I've run a lot of cardiac arrest using lidocaine. I've had good results with it, so I like lidocaine. So let's take a look at polymorphic wide complex tachycardias because they're different than monomorphic wide complex tachycardias. Remember, with regular monomorphic tachycardias, wide or narrow, if they're symptomatic, showing signs of shock, we cardiovert them, synchronized cardioversion. Wide complex polymorphic tachycardias, we have to defibrillate them. Usually because it won't sync up with that. With that wide, bizarre, polymorphic rhythm, the machine may not sync up to that. And we don't want to delay defibrillation or providing electrical therapy to an unstable patient. So, VFib, pulseless VTach, polymorphic wide complex tachycardias all get defibrillated. Not synchronized cardioversion. That category we defibrillate. So remember, pulseless VTach, VFib, wide complex polymorphic tachycardias get defibrillated, not cardioverted. So let's get into our wide complex tachycardia arrest today. We're in the ER, and today you're the ECRN in charge. You work in the ER when you get a call coming in for a cardiac arrest. Let's pop over to the ER.
Yeah, Rampart, be advised, we're about 2 minutes out from your facility. This is for a 55-year-old male. He was a witness to arrest at his office. Co-worker started CPR. Stop touching that. Stop it. So we have students on board. CPR was started immediately. We've defibrillated him once. Patient remains in VFib. We're working on getting an airway and getting a line in him. Again, we're going to be at your door in about 2 minutes.
Okay, so you're the team leader. You know you have a VFib arrest coming in your door in about 2 minutes. What are you going to need? You're going to need someone to continue doing chest compressions. However, the paramedic or EMT working him is probably going to keep doing that until you're ready and all set up. You're going to need someone to manage the airway. You're going to need someone to get a line in this person, someone to administer drugs, someone to document, to be the historian, write down what's going on, and someone to run the code. That's you. So you see the patient coming in through the doors. Good, we get him in. We're going to get him whipped over to our monitor real quick. Take a quick look at him and we see this. VFib. Check a pulse. Again, we check for a pulse no more than 10 seconds. Patient does not have a pulse. We immediately set up for immediate defibrillation. Continue chest compressions until the defibrillator is ready to go. We shock the patient. Immediately resume chest compressions after the defibrillation. Look at the monitor. Patient remains in VFib. Okay, the nurse is telling me now we have an IV. We have an 18 gauge in the right AC. First drug of choice, epinephrine. 1 milligram, 1 to 10,000 IV push. Remember to follow that with a 20 cc syringe bolus of saline. Push that drug to the heart. We could replace it with vasopressin. The first or second dose of epinephrine can be replaced with vasopressin, again 40 units. But we have the epinephrine, so we give the epinephrine. Continue chest compressions for 2 minutes. Patient remains in VFib. We defibrillate again. Immediately we start chest compressions after that defibrillation. Next drug up, amiodarone. 300 milligrams IV push. We administer that. Continue chest compressions for 2 minutes. Look at the monitor. Patient remains in VFib. We defibrillate again. Boom. Now we have a rhythm change. Anytime you have a rhythm change, check a pulse. In this case, we have a pulse. He has a regular, narrow complex pulse that we see. We check his blood pressure. Blood pressure is 110/70. We now have an advanced airway in. We've intubated this patient. And there's no real guideline on when do you intubate a patient. When do you perform your advanced airway? Generally, after my second shock, I'm looking to tube the guy. I want that advanced airway. I want to make sure that I can ventilate him adequately. But there's no hard and fast rule on that. But generally, that's what I do. I've had to shock him twice, we intubate him. In this case, we have an advanced airway. Patient's starting to buck a little bit. Doctor sedates him, and then it's off to the cath lab to fix this guy's heart. Nice resuscitation. Let's take a minute and talk about return of spontaneous circulation. We have an organized rhythm. We have a pulse. What are we going to do next? First, address the airway. Make sure the patient is adequately oxygenated and ventilated. You want to achieve an SpO2 of at least 94%. And continuous capnography is also appropriate. Use your end-tidal CO2 to look at if this patient's perfusing. You look at their saturation to see if they're oxygenating. You look at your capnography to make sure they're perfusing. Next, look at their blood pressure. Do they require blood pressure support? Do they require fluid boluses to keep their pressure up? Do we need to start a pressor infusion to keep their blood pressure up? So maintain a good blood pressure. If your hospital has the means, consider hypothermic therapy right after a return of spontaneous circulation. The literature supports this and it shows a better neurological outcome in the patient. The goal is to achieve a body temperature of between 32 and 34 degrees Celsius. We can achieve this by infusing cold IV fluids, using cooling blankets underneath and on top of the patient. And this should be started within minutes of a return to spontaneous circulation. Next, get a closer look at this heart. Get a 12-lead EKG. Does this patient need to be going to the cath lab? We've had a spontaneous return of pulse and circulation. We need to get a closer look at that heart and fix the problem. Are they having a STEMI? Are they having an ST segment elevation myocardial infarction? Do they need to be going to the cath lab right now? Get a 12-lead. Finally, need to get this patient up to the ICU. Start the recovery process. Get this patient healed and get them home. Thank you for watching today's MegaCode presentation on wide complex tachycardias. My name is Mark for ACLS Certification Institute, and I will see you in the next film. Consider hyperthermic therapy. Yeah, bake them in an oven, 350 for 45 minutes. Remember to baste well.